Hello, and welcome to the ACR Journals on Air podcast. I'm your guest host, Mhert Mar, filling in for Vicky Shamagan. As many of you may be very well aware, there are not enough rheumatology specialists in the United States today. That means that patients are not getting the care that they need in a timely manner, that clinicians are being overburdened, and that healthcare systems are becoming more and more inefficient. Today, we'll be talking about one solution to this growing workforce crisis, the training and greater incorporation of physician assistants, also termed physician associates, into our specialty. But who exactly are these PAs? We'll be talking about the demographics and practice characteristics of PAs practicing in rheumatology. The manuscript that details this is Profile and Attributes of Physician Assistants/Associates in Rheumatology, an in-depth analysis. It was published in Arthritis Care in Research, and a link to the manuscript and disclosures are in our show notes for today. We are so grateful to be joined by the first author of this study, Dr. Benjamin Smith. Dr. Benjamin Smith is the Program Director and Associate Dean at Florida State University College of Medicine School of Physician Assistant Practice in Tallahassee, Florida. He has worked as a rheumatology PA for 25 years in Thomasville, Georgia. He has served in numerous volunteer and leadership roles for PA and rheumatology organizations, including the American College of Rheumatology and the Association of Rheumatology Professionals. Ben has published and presented on clinical rheumatology, workforce, medical education, and geriatrics topics. He is a 1999 graduate of the Medical College of Georgia PA program and completed additional graduate trainings at the University of Nebraska Medical Center and the University of Lynchburg. So welcome, Ben Smith. Before anything else, I wanted to start off with how compelling your article is. The first few sentences are absolutely stark in showing the workforce crisis. Can you tell us a little bit about what the challenges are?
Well, great, Dr. Kumar. And thank you for this opportunity to talk about a topic that's tremendously pertinent. I think that it's been well documented in the medical literature, and the college has done a wonderful job highlighting the starkness of the rheumatology workforce and really things as they are now and things as we anticipate they'll be in the very near future. Close to 5,000 number deficit of rheumatology health professionals, rheumatologists, PAs, and NPs. And I think that's stark. I want to be a little anecdotal here, though. I've worked in a rural setting throughout my career, 25 years, where patients have to drive hours for their rheumatology care, not enough rheumatologists, and the work that we do is with expertise. And I think we can really drill this down to a patient level and this desire that we all have to deliver optimal patient care. But none of us can work 24 hours a day, 7 days a week. It's just not ideal that we would do that. So with the advancements of science, the advancements with treatment, with diagnostics, with everything we do in rheumatology, we're grateful for that. But the workforce to sustain that good work is so needed, and it's a recognition that we all have. We felt it individually, and I think we feel it as a big healthcare system in the country and really around the world, quite frankly.
Yeah, absolutely. It really strikes me as well, again, in a predominantly rural area. Those 5,000 deficit of rheumatology clinicians out there, we have to also remember that that was from 2015 that they projected that. The future is here, right? Any thoughts?
Yeah, we're right in the middle of that. Kind of that endpoint was 2030, and I had the great privilege of working on both of the prior workforce studies. And from the first workforce study to the second, there were even modifications which showed a greater supply and demand gap that existed. So the literature is helpful, but we're really living in this today and feeling this. And I think that's the importance of innovation. And we hope that our work continues to highlight that and bring that to be so that we all can be innovative in thinking about those things that are to be done.
Absolutely. And, you mentioned innovative, but PAs are not really innovative in the sense that they've been in our specialty since the 1970s. So can you tell us a little about the history of PAs in rheumatology? This is a story that I'm not familiar with at all, and I think that our readers would love to know about, or listeners would love to know about.
Yeah, thank you for this question. And I'm going to actually expand that a little bit to PAs in general. So middle 20th century, a lot of things were happening. Population was growing, baby boomers were being born. Insurance as we know it was really developing both on a national level, but with independent payers. as well. There was a tremendous need of increase for healthcare providers, for healthcare delivery in our country. Medicare, Medicaid came on the scene. A couple of really global wars occurred. Innovation happened with that. Science moved forward. But there was a real recognition. And so the PA profession was born with these return of experienced individuals who gained that experience in the military. Dr. Eugene Stead, family physician, landed at Duke, trained at Emory. He recognized the value of these corpsmen who were returning home. So the first PA program began at Duke in 1965. Shortly thereafter, in the 1970s, the first PAs entered practice into rheumatology, really the pioneers. And I think although they were few in number, they really laid a groundwork of steadiness and gaining recognition individually for the profession and to what is to be done. We highlighted in the article that that number has now grown to 430. The latest data is there's 454 PAs that work in adult rheumatology, only 4 in this data that in pediatric rheumatology, but it highlights the need. But I believe, and through interaction with those early PAs in rheumatology, that they laid a very solid foundation for those things that are to be done, providing care and doing it in a very respected way that allows us who have come later to make a difference. As we think about rheumatology and treatment, how it's developed over these number of decades, we could parallel PAs in this field as well as really one of those discoveries, if you will, that is so vital and so helpful.
Hmm. Yeah, and EAs in rheumatology have been here for half a century or a little bit more. And, as I was reading, I would think that it would be easy to identify the PAs in rheumatology, right? I mean, like literally, you mentioned for pediatric rheumatology PAs, there's literally, you can count them on one hand. But then I was looking at the materials and methods section, and it seems like you have to cast a very wide net. Can you tell us how you found these PAs for your study?
Yeah, this is a great question. And this is the question that really caused many of us to scratch our head for years. And I should go ahead and add, and I would like to talk about nurse practitioners today while we're together as well, but how many NPs and how many PAs truly do work in rheumatology? And we would ask a number of folks who you would think should know, and we could never find that number. The NCCPA, National Commission on Certification of PAs, is a tremendous organization. It's the national certifying body for PAs. And of course, they have their finger on the pulse with all PAs, and they survey, they query, those PAs as they maintain certification. And so part of that survey includes where these PAs practice and where they work. So this rich data provided a grand opportunity for this descriptive work that we've done to really think about the demographics and who we are. So they're an outstanding organization with which we had the opportunity to work with to look at this data, to ask questions that are pertinent and specific to PAs. And it allowed us to get a broad reach across PAs in rheumatology. And really, our goal was to compare to PAs in other medical specialties as well. And I think it gave us a helpful insight. So that was the net we were able to cast. And, went through another organization that certainly has this question at mind specific to rheumatology, but all healthcare as well.
So you cast this wide net. I'm glad that you had this giant database from NCPA. What did you find? Who are these PAs in rheumatology? And how are the professional profiles of rheumatology PAs different than the PAs in other specialties?
Yeah. So, first off, the general statement again, our data showed the answer came that at least in 2022, the data that we used, there were 430 PAs in rheumatology. And that number helps us to recognize that the number of PAs in rheumatology has trended upward. Our starting point was 2015, where there were 222 PAs. So the trajectory is up. We found in the data that most PAs were female and most worked in larger, more urban settings, certainly in office-based outpatient type settings as well. And likely that's not a surprise. I mean, in many ways, that mirrors our physician colleagues as well. But I think this helps to reinforce that very, very good information. The other thing, and this is true of the profession as a whole, PAs who work in rheumatology are young in age, the average age of 39, and that's very comparable to PAs in other specialties. The PA profession as a whole is a young profession, both in terms of the profession's age, but also those who work as PAs. I think it was striking to note the number of patients seen by PAs in practice. And I think this is really helpful to note. And we talk about PAs being one answer to the rheumatology workforce needs. And I think PAs, this data suggests, certainly can contribute to helping to provide access in patient care. The other striking thing from the data is PAs who work in rheumatology are happy. They're satisfied. There's very low desire or plans to move to another specialty, which is one of the things that people often view as a value of the profession, a strong and positive characteristic that throughout your career as a PA, you can transition from this specialty to that specialty or this setting to that setting. But it's interesting, we find, and the data supports that PAs, when they land in rheumatology, they often find it to be very satisfying. Studies in the past have shown that rheumatologists are some of the happiest physicians in medicine. And I think that certainly can be said about PAs as well. PAs who work in rheumatology also have low levels of burnout. And that's an important data point to recognize and to see, particularly in the state of medicine and as we think about health professionals today. So the data being able to support that, I think, is helpful to know as we think about and consider the future.
Yeah, and that's something that really struck me too. So I'm actually going to ask two questions. I'll do them sequentially. The first you touched upon earlier, and it's here in table one. So if you compare PAs in rheumatology versus PAs in other specialties, it seems like the self-identified women, it's so much higher in rheumatology PAs, right? So it's about 85% compared to about 70% for PAs in other specialties. Do you have any speculation on why that's the case?
I don't know that I have a perfect answer in that regard. The PA professional as a whole, when we compare female to male ratios, it's about a 70-30 breakdown. And that certainly has changed over time. But why statistically we look at PAs in rheumatology being more female than male, I don't know that I have a specific reason for that. I will offer a couple of other suggestions that may contribute. In recent years, the number of PAs in specialties has changed. There's been some shift. Whereas in the past, most PAs worked in a primary care setting, family medicine, perhaps internal medicine. In recent years, the last 5 to 7 years, that shift has occurred. And so most PAs, the largest number, work in a surgical subspecialty now. So maybe there's something to be said there that may be helpful. Generally, PAs in rheumatology often work 8 to 5 hours, 9 to 6, whatever it might be. That may be a draw for certain individuals as well. I wonder if that may contribute to the gender distribution that we see represented.
Yeah, and of course, it might also just be a statistical quirk. I'm not a statistician, right? But there are 430 folks out of 10,000, right? So that may be the case too, but it's such a fascinating data point. And then the other fascinating data point, and you touched on this too, is compared to other PAs in other specialties, rheumatology PAs have a higher patient burden. That is, they see more patients weekly, but they have lower levels of burnout. That is so fascinating. Any ideas about why that's the case and what we can learn from that for other interprofessional team members?
Yeah, so I think that's a very impactful data point. A couple of thoughts come to mind. I don't know that I have the underlying cause and reason why that is, but I think that the key data point that comes from that is this concept and this idea that PAs, once trained, once they have that rheumatology acumen, competency, they're able to come in and contribute in a very productive way in terms of sheer number. Of course, that affects revenue and reimbursement and such as that. But PAs are able to come in, establish those relationships, and subsequently contribute to, again, access, but contribute to the productivity of the practice. And there can be a routine in that, whether it be follow ups or perhaps new patients, which we can talk about, but how to best utilize the PA. But I think the point is we know that there are practices out there, really around the country, that have brought a PA into their practice and a nurse practitioner and are using them in highly efficient ways. And I think that number, this moderate number of patients seen per week, is one indication of that. And so I think the model, because of the foundational training that the PAs have in their formal education, it allows them and it lends itself to really making a difference in our specialty, rheumatology.
Yeah, and that's the half glass full kind of thing. The half glass empty thing that comes in like the next paragraph or so is that the median income is lower among rheumatology PAs than PAs in other specialties. So I think I may understand why that may be the case based on early pieces of the conversation. But can you just tell me, before I make any assumptions or anything, why do you think that's the case? Like these three data points, seeing more patients, having lower levels of burnout, but also being paid less than other PAs on median. This is a really fascinating kind of pattern.
Yeah, so thank you. And I appreciate the glass half full optimism point that you made there. I think that's really important. I believe, and we reference this in the paper, that when we think about rheumatologists, for example, certainly salary is something that we think about. It's, again, I hope not to misrepresent it, sort of middle of the road for other physicians, but I think salary is very important. Financial stability throughout our career is of value. But we recognize there are other things that bring satisfaction, that bring happiness as well. And I think just being open and transparent about that is very important. Over decades throughout my career, it's been striking to see the increase of PA salaries over time. And again, I think that also highlights the value that the PAs bring to practice. But I think if we're open about that and share that as we've done in the study, it provides us an opportunity to let people know who are interested in this field that this is an opportunity. There certainly are benefits. Priorities happen for each individual person, but I think this is something to be noted. I don't think I was completely surprised by that figure, when we look at salary data over time. I hope that's helpful.
I think it's very helpful. And I think the point that I'm trying to get at is all rheumatology clinicians need a pay raise, right? That's the big thing. But I was also just thinking that based on what you mentioned earlier in the conversation, that PAs are increasingly going towards surgical specialties. Sounds like more hospital based kind of things. Maybe that would be a reason why the median salary seems a little bit lower than other PAs. In a similar way for other physician specialties, for example, the more procedural specialties get a higher median income.
Yeah, it's kind of that cognitive versus procedural based specialty discussion. And I'm grateful to ACR for their efforts to address this. I think that we all have to be diligent in increasing the public and stakeholders and policymakers' recognition of the value of rheumatology and what we do daily, face to face and with patients.
Yes, and it's interesting that you mentioned about face to face because I really like this in your discussion. It's apparently not just face to face, but it's telemedicine now as well, right? That PAs are increasingly using the newer modalities and helping to bridge those access issues you were mentioning a little bit earlier in rural settings. Can you tell a little bit more about that?
Yeah, so I think this was also an interesting point that percolated from the data. And certainly we recognize the COVID-19 pandemic effect on this. I remember our practice 15, 20 years ago, we considered telemedicine and decided at that point not to pursue it. Now times have certainly changed, but we show that the PAs in rheumatology can make a difference and have utility with technology such as telemedicine. I think it's really important to recognize this. We think about patients who may live in remote areas. How can we best reach them? Practice may have this question. We hope to stimulate the possibility, some thought and discussion on is PAs can help with that telehealth delivery that may happen. I know there are other things, responsibilities, maybe challenges to be addressed with that. But again, at this time of innovation need, we want to suggest that that is certainly a possibility. Again, we know there's structure that needs to be developed, and certainly policy may affect this, but EAs can have a role in that as well. And our data suggests there's a willingness to contribute positively in that way.
Yeah, and I just need to introduce this before I forget it. Let's just talk a little bit about the data and just some limitations because I love the comprehensiveness of the data, but there are limitations. So can you tell us before we read way too much into this, what readers and listeners should be aware of in terms of the methods?
Yeah, thank you for that. We must always do that as we think about data that we analyze, the literature that we review. So first off, this was a survey, and so it's self-reported data. The response rate, while very, very high, is not 100%. And there were thousands of respondents. We're grateful for that. So self-reported data. I also, again, would love to include similar data for our great colleagues, nurse practitioners, as well. And while that's not an absolute limitation in this study, I think it would enrich what we have here. While the NCCPA has a far reach and a large net, as we described earlier, are there those who may have been left out? Certainly, that may be the case. So I think the data, the survey data, gives us an opportunity for further validation, but we do recognize the limitations that have been mentioned and described.
And this is another thing that I just jotted down before, and I wanted to ask you before I forget. So, what is the specialized kind of training that rheumatology PAs get, after PA school and such?
Yeah, so I really appreciate this, and this may be a great educational piece for our listeners today. In formal PA training, there is a limited amount of rheumatology content that is delivered. I think back to my PA school training and now work in a PA program, and there is content that's delivered. In the clinical portion, certainly PA students do see patients with rheumatic disease. That's great. I remember as a student, actually was doing a nephrology rotation and in an inpatient setting and saw a patient with lupus who was hospitalized with lupus nephritis. So I will never forget that. And subsequently, I went to work with that rheumatologist thereafter. So that was great. So there is some training, but in large part for PAs and NPs who are interested in working in rheumatology, the post graduation experience is where the large part of that opportunity of learning comes. Now, the college has been tremendously helpful in this in publication of the rheumatology core curriculum for PAs and NPs, and that was just updated last year. But there's a publication, I believe it's from 2018, that really highlights that can be applicable to a practice's needs, as a guide. The college has also provided the Advanced Rheumatology course, which is an online training course, which is really, really well done. I say that with bias because I had some role in that, but I think it's very comprehensive to begin and continue that process for PAs who are new to the field. But like a physician residency and then fellowship in rheumatology, I think it's really that core mentorship that makes a tremendous difference. In my early days in rheumatology, I'm grateful to my colleague, my supervising collaborating physician, my friend, my mentor, Victor McMillan, because he invested the time to help me be up to speed from history and physical to treatment to everything in between. And it really required after clinic, it required during clinic teaching. And so I would suggest there is an investment, but I also believe there's a return on that investment on many layers that do occur. So there is formalized training. There are other organizations outside of the ACR who also contribute very greatly, but I applaud the college for what they've done to support PAs and NPs over time as well. So it's really bringing all of those things together that lends itself to the development of a PA, nurse practitioner, who help to provide quality and optimal care to patients with rheumatic disease.
And, as you've mentioned in this previous answer and also throughout this entire conversation, this is fast in terms of changing, right? In the paper you mentioned, there's a 93.7% growth since 2015. Sounds like that number is already out of date since they already added 24 more people, right? So, how do you see this PA workforce changing in the coming years? How would you like to see it change?
Well, this is really good. And this is the opportunity I think that we all have. And I would suggest that we share some responsibility. And I don't want to suggest that this growth from 2015 to 2030 and before just sort of happened randomly. I do think there have been some real champions and people leading the way. But I think as we all think about choosing rheumatology, as we all think about recruiting and encouraging our colleagues who are early in their career, in their training to consider rheumatology, I think many of the principles apply. I think those of us who work in rheumatology, going into programs and teaching, I think serving as preceptors, really having conversations in maybe even in social settings where appropriate about our passion about this field. I think all of that applies to PAs as well. We think about how many of us ended up in rheumatology. It was because of a mentor or someone that led the way and was very influential for us. I would suggest that that applies to PAs and to MPs as well. If you're in a practice and your wait list is tremendously long, your days are long, I would invite you to consider this opportunity to bring someone on board. I think we've seen positive growth, but I believe there's opportunity for enhanced growth. And I'll even use the word, this may be too forward thinking, of exponential growth in this. And I think it's highlighting the value, maybe work-life balance, perhaps, the satisfaction we have with long-term patient relationships, the science and the way that it's advancing rapidly. I mean, this rapid workforce advancement, I think, can also be highlighted and paralleled with rapid scientific advancement as well. So I think coupling all those things together, with passion and with excitement is the opportunity that I have and that we all have to do this and really making an impactful difference where we find ourselves.
And certainly you've warmed my heart in terms of all these opportunities that are there. And it makes sense in terms of the data that you've collected, right? That despite doing more work, there's lower levels of burnout and greater retention within the specialty. And that provides opportunities for growth. On the flip side of the coin, can you tell us a little bit of the barriers that you guys are facing in terms of this expansion in workforce?
Yeah. So I think a couple of things come to mind when we consider barriers. I think helping all, and I'll use the word all here, but helping many others recognize the value and opportunity to incorporate and create this interdisciplinary team that's inclusive of PAs and nurse practitioners as well. I'll continue this answer by also saying, and I suspect we may be going here in the future, but I'll take the opportunity now is to talk about where we go with research. What's next? I mean, because I really do see this manuscript together with other good works that have been done as being a starting point. Oftentimes we're asked, how do we best incorporate a PA into our practice or a nurse practitioner for that matter? And I can give you many anecdotal experiences and recognition that practices here and there may include PAs in various ways. But what's most optimal? What is best practice for PAs in a given practice? And I recognize that practices have different needs as well. But I think that opportunity, it's currently a barrier because perhaps we don't know the best answer, but I think it actually becomes an opportunity to discover that answer in terms of what's the economics of this? What is the day-to-day logistical inclusion of a PA or an MP into a rheumatology practice? And, again, there's heterogeneity in practices, but how do we best do that? What are the principles that we should consider? And I do think that's a tremendous opportunity for consideration that can maybe a barrier now, but we can break down that wall as we look towards and move to the future.
Yeah, absolutely. In fact, you kind of took the words from my mouth in terms of the next question, in terms of how are you going to use this data for future research? It certainly does sound like this is only the beginning of something much, 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 much larger. In lieu of that question, let me just ask if you could have 3 points that you wanted to hammer into the head of our listeners, what 3 points would you propound?
Well, at first, it's very obvious perhaps, but PAs are one solution to the tremendous workforce challenges, that large supply and demand gap that we face in rheumatology and the rheumatology workforce. And I would just ask that we all recognize and consider that option. We now have several decades of experience and some data that support that use. Second, there is an investment in onboarding or utilizing PAs, a knowledge opportunity, an opportunity to sort of figure out the logistics of what this looks like for an individual practice. And then third, I would suggest that we as individuals, we're grateful for the reception of this work and the interest that has come in various formats and in various settings. But I would highlight that we as individuals can make a difference. Yeah, there's thousands of patients with rheumatic disease out there, but when we think about onboarding, increasing the number of PAs or MPs, that you and I can do things to make a difference really on a daily basis in that way. What do I mean by that? I mean, state law, state statute, scope of practice type opportunities really do exist, and our voice, can make a difference. So PAs are a part of the rheumatology health force. Let's recognize that first. There is an opportunity to increase, knowledge, skill, and attitudes and competency of PAs in rheumatology, and that you can make a difference in this, even as one individual to help us move forward in this tremendous opportunity that exists.
Awesome. Well, I wish we could continue this conversation even further on the podcast. I'm sure that we will have more conversation in the future because this is just burgeoning. But unfortunately, that is all the time that we have for today. I am very, very, very grateful for your time, Ben. It's been absolutely enlightening to see how you and so many others are working to fix the workforce shortage because we need multiple solutions for it. I would also like to thank all the members of the interprofessional teams who support the millions of people living with systemic autoimmune and rheumatologic diseases throughout the United States and beyond. It is really a cliche, but truly, rheumatology is a joint effort. So thank you all for listening to this podcast. We will see you all next time. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast on acrjournalsonair.org or wherever you get your podcasts. Take care.